How's everybody doing?
Good. I think I hear them coming down after I told them just not to come down. So we'll see how it goes.
All right.
All right, so there's a ton of questions. I think what I'm gonna do, if it's okay with you, is just throw it in the chat. That way it's easier to address it that way.
Sure.
Is that okay?
Sure.
All right, sweet.
Yeah, absolutely.
There's a few that are very similar, so I kind of grouped them together because it's almost the same question, just kind of worded a little different if you want to check it out that way. All right,
Sure.
I'm gonna stick it in. All right. Did it all go through? Yep. Okay. All right. Did it go through to you?
All
right, there we go.
There it is.
There it is. Okay, this looks like it cut off a bit, so I'll just give that for now. Hold on.
Okay, yeah, I pulled it up here. So the question, and I'll just read it out. So double outlet right ventricle and ventricular septal defect. My child has double outlet right ventricle ventricular septal defect, chordal tissues from the mitral valve that go across the ventricular septal defect. Is it possible to cut cords and reattach them in order to close the VSD and do a biventricular repair? Great question, and I'm just going to share. Can you, Joe, can you enable share screen?
Yeah, it's not on there?
So I can share my screen and just draw something?
Yeah, absolutely.
Hold on, why isn't it letting me do it? Ava, help me do the share screen thing because I don't know how to do it. I know, an old lady, shush. Do I go into settings?
No.
I have Ava help me. Sorry.
Oh, good. Hi.
Oh.
All right. I like it.
To share screen.
Thank you. Say hi.
Thank you. Hi. Great to see you. Looking good.
Thank you.
Awesome. Oh my goodness. I'm so proud of you.
See how big she is?
No,
Oh my God.
Yeah, that's great. Oh my goodness. It's been a long time, but
I know.
that's awesome. Well, good job. Are you on school on another computer over there? Are you virtually
Upstairs, but yes.
Okay. All right. Well, I'll let you get back to it. I won't keep you from it. Good to see you. All right. So.
Oh, the Zoom schooling. I love it.
Hi.
Hi. So I just,
Hey,
Jill, hi, how are you, Ram?
Hi, good.
Jill, I just texted you. I'm sitting in my car because I got called into the hospital, but I think this patient's a little sick, so I should probably go inside. Can you and I maybe find another day where if people want to talk about kind of long-term stuff, we can talk about growing up and adult stuff with CHD? Would that work?
Yes, absolutely. I have a million questions for you, so yes, definitely.
Fantastic. Let's plan on that. I will text with you. And Ram, it was nice to see you for a few seconds at least.
Yeah,
I'm gonna step away.
All right.
Have
Bye-bye.
fun, you guys.
All right, bye.
Yeah, I think the one thing that we have realized is that, I'm sorry, I'm going to draw on my whiteboard here. One thing that we realized as we've gotten more adept with valve repairs and complex anatomy is that we've developed new techniques that just weren't available to us, even 10, 15 years ago. And so traveling cords is one example. So I'm going to draw a picture that sort of shows what we're talking about here. So let's say you have a left ventricle down here, okay? And here's a ventricular septal defect here. And here's technically where the tricuspid valve should be, and this is where the mitral valve should be. So you can have, in double outlet right ventricle, you can have straddling cords that go either way. That is, what a straddling cord means is that normally the cords should attach onto the same side of the ventricular septal defect. But in some patients, the cords can kind of come over and attach onto the right side of the ventricular septal defect, okay? In that situation, people have thought, wow, there's no way you're going to be able to close this defect here because you end up with, you end up with a cord that's kind of stuck, if you will. So there are some new techniques that we've developed to try to generally address this. And so let's think about them in a couple of different ways. The first one of which is really depends upon the location of this papillary muscle. If the attachment is close to the septum, if it is close to this area here, what you can do, and which works really well, is we can just tack this papillary muscle onto that ventricular septum and then place our patch over here so that it doesn't interfere with the chordal attachments. And so that is probably the most common way that we address it. We just put the patch way onto the side and actually sew the patch to the papillary muscle below where all of those attachments are coming in. And that really, honestly, doesn't take any more time than actually it would be if there was no straddle. And it's kind of, the outcomes of that are pretty good. And in fact, if you think about it, if you have a double outlet right ventricle, you have an aorta that's actually coming off of the right ventricle, say here. I know this is a horrible drawing, and I really apologize for my drawing in advance, but we need to get some of our young artists to help me out. But you can imagine that I need to also baffle this over to the aorta. So in a way, it actually sets itself up because I'm putting my patch more onto the right side of the heart anyway, that I can actually put the patch in such a way that the attachments don't get interfered. Now, there are some situations in which this attachment looks like this, where it goes all the way over here and attaches to a papillary muscle that's on the opposite side of the ventricle. Well, that's a different situation. In that situation, I can't do this because I would like be putting a patch like that, and it wouldn't work. You wouldn't have enough right ventricle. So in that situation, what we've started to do is we attach a papillary muscle and then move it over to the left side and reattach it here, and then use that papillary muscle on the left side and then close the ventricular septal defect the normal way. So there are a number of techniques that we've developed. The bottom line is that doesn't preclude a biventricular repair anymore. Okay, so that was, any questions about that? All right, now I'm going to move down the list. And so I'd like to know how many straddling tricuspid valves we've disconnected and reattached successfully, and how many leaflets of the valves straddle, and how many tricuspid valve replacements have we had to perform. So that is, that's a good question. Again, I'm going to go back to my drawing board here, and then sort of, I'm going to type out. So approximately, I don't actually have the actual numbers on us, but in general, we've probably done around 20 to 30 repairs of straddling valve in the past 4 or 5 years. I would say that the majority of these patients have the kind where you just where you're just tacking the papillary the papillary attachments over onto the ventricular septal defect, and that's usually sufficient. I would probably say that 80% of the time we can get away with that, and that leads to less distortion of the valve, and I like that. I prefer that. I try to do that whenever I can. I try to just keep the overall, because what that does is that preserves the overall length of the cord, and that prevents us from having to kind of shift it. Now, if you do have to do a reimplantation, that's again probably about 20% of the time that we have to do that. I would say that that's probably a little more risky from the standpoint of needing to come back, but I would say that of these, it's maybe a handful that maybe around 3 to 5 patients that will ultimately that have needed come back for further repair on that valve because either that cord has stretched a little bit or that papillary muscle has gotten detached or something. But it's not the end of the world because in those patients, we're still able to repair the valve again. In most circumstances, the repair is still possible. And that's just because we now have something called artificial cords. And these artificial cords can just replace an existing cord. And so that's one technique that really helps with the valve repair. Other things that we can sometimes do are close off a part of the valve that was supported by that area, and that can sometimes be possible as well. So I would say that, you know, in this group of patients, a replacement of the valve, of the straddling valve, whether it be right or left side, has been extremely rare. And I can only think of one situation in which we had to do that so far, and that was one of our earliest patients. In retrospect, I think now we probably still would have been able to repair the valve. So I would say that our learning curve for this and our techniques are really changing dramatically over time. Any questions about that? Okay, and Joe, I mean, just again, stop me if you think I should go in a different order, or if you want to, you know, if there, you know, if you're seeing a call out that you want me to address before I move on. Otherwise, I'll just keep running down the tab list.
Can I ask a quick question?
Yeah, please.
Hi. Yeah, so it was just on what you were saying before about patching to the papillary muscle.
Yes.
So is that instead of patching to the septum, you just forget about the septum altogether and patch to the muscle, to the top of the septum?
You sort of unify the papillary muscle with the septum. So you make the papillary muscle part of the septum, and then you lay the patch onto the papillary muscle, which has been attached to the septum. So it closes the VSD effectively by making that by pulling that papillary muscle close to the septum. It makes it part of the septum, if you will.
Oh, okay. So you move the whole thing onto the septum and then close the hole.
But you're not detaching it. You're just kind of pushing it over onto the septum rather than detaching it, which is kind of a different, you know, now you're actually, you know, if you detach a papillary muscle, then, you know, you have to reattach and there can be, you know, more instability. But if you leave the attachments and you just kind of move it over.
How do you move it though, without like cutting it?
If it's close enough, so when I was drawing the figure, like what I was trying to show, and I probably wasn't drawing it properly, but you know, if you imagine the left ventricle here, and let's say you imagine a ventricular septal defect here, and you imagine that the papillary muscle, let's say it's attaching down here. What I'll do is I'll take a suture and I'll just close that space between the papillary muscle and the ventricular septum. So now that brings that papillary muscle close to here. So now it's essentially, it looks like this, and it almost, you know, becomes part of the septum. And so that chordal attachment now is kind of coming off like this. But if I put that patch and sew it right here and then continue it around the ventricular septal defect, it doesn't disrupt the length. This length here, you know, this length right here, from here to here, that remains the same as if you did nothing, but it closes the defect.
And is that possible when it's straddling through the VSD as well, or only if it's?
This is particularly if it's straddling through the VSD.
Right, okay. So then I guess you're not messing around with like the tautness of the cord at all, because you're keeping the length the same. So
bingo.
There won't be any regurgitation.
Exactly. And that's why I like this technique. Now, the exclusion is that I can't do it if it's all the way on the other side of the wall. I can't do that anymore. So that's the situation in which I have to detach it and then move it over to here somewhere.
And have you done many of those where you've had to take it from the other side?
Yeah, we've done, like I said, probably of the 30 or so patients that have had straddling valves, it's probably 4 or 5 that we've had to do this. Again, not huge numbers, but you know, I think that it doesn't preclude a bivy repair, and I think that in general, the outcomes, even though there may be a potential need to go back and readjust it or re-operate on the valve, you know, that part is less scary to us now because we feel like, you know, we have better techniques for valve repair. But it doesn't necessarily, I mean, it does work too. So that's why we've been.
And if you had to go and do additional repair, would that be soon after you had done the moving of the papillary muscle, or is it normally like later down the line, or?
It can range. It can range. I think if we're going to see something happen, we're going to see it within the first 6 months or so.
Okay.
But you know, we have seen some that need something done even within the first, you know, weeks. And this is true of any complex valve repair, is that there are 2 timelines for needing something done. There's the early phase, which is usually, you know, a suture or something that tears or something that shifts early. And that's usually within the first week or 2. And then there's another phase, which is generally in the months phase. And that's where the heart is remodeling. That's where the tissue is kind of changing configuration a little bit. And that time course is a little bit different. It's in the order of months, and we can see things that change and require reintervention. And then rarely, if we see a valve that looks good at 6 months or a year, sometimes it can still change, you know, 5, 10 years down the road, but less common.
Okay. And you were saying that the synthetic cords help.
Yeah. The synthetic
And why
cords
is that?
The synthetic cords are basically, they are a technique that we've started to use more commonly now. And these cords are, they're actually, I'm going to pull one of them out. So these cords actually are made out of a material that is called Gore-Tex. So for those of you parents who have been familiar with BT shunts, with Fontans, material that we're using to repair, to do those connections is called Gore-Tex. Now, I don't know if you can see this, but this is what a Gore-Tex cord looks like, and it's basically a suture that's really, really fine, and what it allows us to do is to put one that goes to the papillary muscle, one that goes to the leaflets. And so we basically take these sutures and we put this string through the leaflets. And it's actually a really nice material because it's pretty strong and it's really thin. And so over time, it doesn't actually, it doesn't tear very much. And so this is why this is a nice kind of addition to our armamentarium, and has allowed us to repair cords and replace cords. So we're not worried about where they're attaching anymore because, hey, we can measure the length of it. We can decide they come in different lengths. So this one right here is a 20 millimeter cord. We can look at the size. We can measure the size with a measure, pick out the size of cord we want. And just like, you know, it would be like, you know, picking a size 10.5 shoe. You pick it off the shelf and you put it in, and it works well. And I think this is something that in the past few years, we've used more and more. I've probably used it now, you know, a good 50 times. And you know, I've been pretty happy with the results. So our techniques for valve repair have changed a lot and are continuing to improve exponentially. And I think that's something that's really important, because what you'll see in textbooks, and not just for straddling valve, I would say for any kind of complex heart disease, anything you'll read in the textbook is going to be behind the times in terms of what is currently possible.
Yeah, why are scientific papers so out of date with kind of new methods? Because if you read you know, like papers and journals about moving straddling cords, especially it seems to be with the tricuspid valve, it's all quite like just don't fiddle with them at all.
Right. So we're in the process now of reviewing our series. So the way that scientific journals always work is we're able to do anywhere between 10 to 50 patients, and we follow them for a year or two to make sure it works. We don't want to jump the gun and do it after our first patient. It's the same thing with the reverse double switch. We haven't really told you guys know more about the reverse double switch than most doctors out there, even surgeons. Many surgeons haven't even heard about it. So that's because most of us don't like to jump the gun until we know that it's going to work. And so that's why the literature always lags behind, is because nobody wants to put something out there until they've proven it, and that generally takes like 5 to 10 years.
Okay, great, thank you.
Thanks.
I did have a quick question. I don't know if you guys can hear me okay. So my daughter also, she has DORV with a VSD. So she also has the straddling cords over her VSD, and she had her Glenn almost a year ago. And we're going to be getting a second opinion with you, hopefully, upcoming, like coming up soon. But my question was, I wanted to ask, you were talking about sort of like tacking of the papillary, and if what would exactly, like, I wanted to ask her cardiologist, I want to make sure I'm asking the right thing. I just like to have an idea, but what would the cord need to be near the papillary muscle? That's what I'm asking her. Like,
right,
that
so
cord needs to be near.
Right. So the thing is the location
Okay.
of the papillary muscle. So the location of the papillary muscle in relationship to the ventricular septal defect, right? Because that's what I want to know. I want to see that. And now echo can sometimes pick that up, but it's really best to pick that up by CT or MRI, because that gives me now a 3-dimensional view of it. But I can see it by echo too, if you get the right echo images.
Okay. Do you? Whenever you have the second opinions sent to you with situations like this, do you usually require an MRI and a CT to be sent? Like, if I were to be proactive, could I send that, or like the echo would be fine? I don't think she's had those.
I think so. Generally, when I'm approaching an initial view, I generally say, give me what you got in terms of information, because sometimes, depending upon where the MRI is done, sometimes you go through an MRI and it doesn't give us the information we need. And so I tend to be very specific about what I want, and some places can do it, some places can't. And if it's information that's critical, I wouldn't want your child to go through 2 MRIs separately. So I would say, if you've had an MRI already or a CT already, great, we'll look at it. But if not, we should just look at what you have, and then we can decide generally what happens from there.
Okay. All right. Cool. Thank you.
Great. All right. Let's moving.
If you want, Dr. Emani, you can address the ones that people just kind of popped up, but
Sure.
more of a different question than
Sure,
the
go ahead.
tricuspid issue. Let's see what just popped up. Let's see. Liam asked, what does it mean if there's an increased blood flow on a conduit?
Depends upon what type of conduit, and what disease process are we talking about? Is this with a stage 1, or is this in a single ventricle who has a conduit, or is this in a biventricular after a biventricular repair who's had an RV to PA conduit?
Let me see if Liam's still on.
Liam's still on?
Asked it. Yes.
Hi.
Hi. How are you?
Yeah. Say hi, Liam.
Hi. Oh my goodness. Hi.
It's after his biventricular repair. It's
Okay.
a year after.
Okay. So we've had, so after a biventricular repair, hi. Good question. Yeah, so there are a couple of things that can happen in terms of the amount of flow across a conduit. That can happen if there are ventricular septal defects or other things that lead to more flow. So that's one thing that you would want to make sure that we don't have is residual ventricular septal defects. Sometimes you can have higher pressure in the conduit that's not necessarily flow related, and that can happen if there is potentially a higher pressure in the left-sided circuit or in the pulmonary circuit. So it would be really important to make sure that we understand that part better.
Okay, one question that's come up quite a bit is the Fontan versus bivent. We know that there's complications the long term with Fontans, liver issues, PLE, plastic bronchitis. Are we seeing any similar issues or other types of issues with the bivents long term? And how many bivents are older? I mean, we know Ava, but
Right.
how well are they doing now? I know we don't have
Right.
a ton of long term, but are you noticing anything?
Yeah, so yes, there are some several important trends. The first thing to keep in mind is that when we think about biventricular repairs, we really want to separate them according to the type of biventricular repair. So I'm going to share my screen again here, and I'm just going to type a few things out. So when I think about a bivent, I think about it in terms of there are several different major diagnoses, and I distribute them by the following categories. Those that have EFE, endocardial fibroelastosis,
Nate, Jane
or
is coming.
or are ventricular, some form of ventricular diastolic function. And that's what the EFE is a marker of. So these are patients that have poor diastolic function. And what I mean by diastolic function is the relaxation function of the heart. The relaxation function of the heart can be poor. So that I'm gonna I'll get to that in a second, but in general, what I think about is dividing it into patients who have EFE or ventricular diastolic dysfunction, and then those that have no EFE. And I think this is really, really important to distinguish. Patients who have EFE, that includes a diagnosis of hypoplastic left heart syndrome, Shone's. In general, these are patients who have no ventricular septal defect. They don't have we don't have a VSD, and I see several of you on this call that I know are in this category. Now, then there are patients who have no EFE. These patients tend to have ventricular septal defects. That includes the double L right ventricles. It includes the unbalanced AV canal defects. Anybody with a VSD is not going to have EFE. Okay, so this also includes the transposition, if you have complex transposition of the great arteries, and this includes double inlet left ventricles as well. And I know I'm missing some. I'm just kind of generally categorizing them, categorizing patients into these two categories. Okay. So now let's talk about long-term and short-term function. One thing that we have realized is that patients who have EFE, they are at higher risk for developing ventricular diastolic dysfunction, relaxation dysfunction. And those are the patients that have issues that can come up in the long run. Okay. And so this is something, this is the patient population that we are going to be much more careful about making a decision about whether to go to a bivent or to do the reverse double switch or just go to a Fontan, because these are the patients that we've noticed have some issues with long-term dysfunction. So it's a different category altogether in my mind. Now, patients who have no EFE, who do not have EFE, have include some of these patients and others that I know that I'm missing. So pardon me in advance. Patients in this category tend to have improvement in their long-term diastolic dysfunction over time. And so patients such as this tend to just get better with time. And so I'm less concerned. These patients have their long-term issues might have to do more with the mitral valve or the aortic valve, or conduit changes, or surgical things like this, but those aren't problems with the pump that that we worry about. So I consider this to be, a little bit more favorable and easier of a decision making. Once you get the ventricles to grow, you get the valves looking okay, you do a biventricular repair, the hearts will continue to adjust. The issue with the patients who have EFE is that even though we can go to a biventricular repair, over time, it's the fibrosis in the heart muscle that can continue to progress. And that can then lead to issues that make the pulmonary artery pressures high, and lead to potential left atrial hypertension. This is the population for which we are now starting to really think outside the box about how to do things differently. We're doing more EFE resections. We tend to be a little bit slower about going to the full bivent. We may be more aggressive about going to the reverse double switch. We're starting to do the mesoblast stem cell trial for this patient population to see if we can improve the fibrosis, so reduce the amount of fibrosis that's in the heart, so that we have a chance of improving that long-term function over time. Okay, I'm going to stop there, and because I know that this is a really, really important topic, and I'm just going to stop there for right now. And to say that in general, generally thinking about it, no EFE. I worry less about the long term. If you have EFE, those are the patients that I tend to worry a little bit more about the long term, and so we're starting to build that into our decision making more carefully now.
Can we touch on the stem cell stuff? I had a few questions on that too listed. I don't know too much about it because I haven't really looked too much, but there was a few questions on, are you guys trying it in between? When do you guys do it? If you are doing it on single vents, expected to be single vents, do you use donor or do you use their own stem cells?
Questions. So there are two major types of stem cells that we're using. The mesoblast stem cell is a allogeneic. What allogeneic means is that it comes from a donor, and it's a healthy donor stem cell. And we found that there's no rejection, so that was an important point. And it's already been shown to be safe in adult patients, adult clinical trials, and so now in over 1,000 patients in adults, and so now we have been using that mostly in the patients that we're doing the staged ventricular recruitment. That's our current trial. So in those patients with small ventricle that we're staging towards a bivent. And in that phase, that's when we're using it, and we're injecting it into the small LV to try to get it to grow. So that's one that's one type. The other type is the there's another trial that we're now part of that's called the ELPIS trial. This is a trial that uses the patient's own stem cells. You have to collect it at the stage 1. So if you've already if you're coming to us with a Glenn or some other stage, then it's not as feasible. But at the stage 1, we collect the patient's own stem cells. Now this trial is to includes injecting it only into the right ventricle, in single ventricle patients. So this is kind of similar to what the Japanese have done with stem cells in single ventricles. It's not so much to get the left ventricle to grow. It's really to say, how do we make the right ventricle healthier in the long term? And so we are now enrolling in this particular trial as well, but it's not really geared towards biventricular repair per se. Any questions about it? And by the way, I'm okay if people want to jump in and ask a clarifying question. You know, this is pretty informal from my standpoint, and so I want to, again, this is pretty informal. So
I do have a question if I can jump in real quick.
Yeah, sure. Hi.
Hi, Emmy. Can you say hi?
Hi.
There's Dr. Emani.
Hi.
Can you say hi?
Looking good.
She's doing great. One thing that I have a lot of parents ask me about is the electrical mapping procedure that you did. I know Emmy was one of the first patients you did that on. And so I get that question a lot from parents just wanting to know kind of more about it and kind of how exactly that works.
Great question. So I'm going to talk a little bit now about the electrical mapping. And you guys, if people want to hop back and forth the subject, that's fine too. But I think this is a really, really important again, we're starting to develop new techniques to help us do biventricular repairs safely. And so the background for this is that, especially in patients with really complex heart disease, a pacemaker is something that is a complication. Okay. And we're trying to avoid the complication of pacemaker in our bivent patients, because the risk of needing a pacemaker in the past has probably been somewhere around 15%, depending upon what type of heart anatomy you have. So one thing that we've started to do is in the operating room, we'll use a little mapping grid. And actually, let me see if I can actually pull it up and share this. Sorry. All right, so I'm just gonna share my screen here, and I'm just gonna warn you guys in advance. This is gonna show a surgical video. If by any chance you think you might get woozy or you don't want to see a video, you may want to turn your head for a second while I show this, because it's an intraoperative video of us using the mapping system. Okay, so fair warning, and here we go. All right, so this is, I apologize, it looks like there, now it's clear. So this is a mapping catheter. So this is an electrical grid catheter that's typically used in the cath lab. And what we're doing here is we're actually using this. I'm looking up at the monitor right now because I can actually put this catheter on the heart. You see the heart is beating. While the heart is beating, I can put this catheter on the area that I want to sew to. So that is a ventricular septal defect there, and I want to put my stitches right there. And I want to know, is the electrical system located right there or not? And so I'll put the catheter grid on there, and I'll actually measure, and I can look up. I'm not showing you the screen that has the measurement on it, but I can tell, oh, is that where the conduction system is or not? This is something that's super novel. We've developed it here at Boston Children's. Again, like Rachel was saying earlier, we haven't really publicized it yet, so nobody really knows about it, although we are going to be presenting it at our AATS meeting. Sort of hot off the press, started doing it in the last year or so. We've done about 40 or so patients, and it's pretty good. It's pretty good at showing us where the conduction system is, and so I can get that view of the conduction system, and I can get a sense of where that electrical system is located before I'm actually placing any of my stitches in that area. And with this, it's really reduced our incidence of needing a pacemaker after surgery.
Oh my God, I could cry just hearing that because that would have saved so much trouble with Ava. Like, I'm glad you guys learned. It stinks that Ava's unfortunately where a lot of you guys learning from, but that's awesome news.
Yeah, this is something that's super, super exciting. It's actually something that we're starting to now, this is really just taken off. One of our colleagues is now actually working on an optical mapping device, so we can actually take a tiny little microscope and put it on the heart and say, oh, here's the conduction system. And we're starting to work on new devices. You can imagine, it's just like, this has opened up a whole new world for us, and we're starting to get into device development and trying to say, okay, can we, you can see how it's a little bit bulky. This catheter is still a little bit bulky for us, and we've got to like hold it on the heart. If you could just take a little, foam and drop it on the heart and kind of get a full map of what it looks like. And, these are the things that we're trying to work on. And so, it's just like, there's a lot of development that we're really, really working on. I mean, unfortunately, we're kind of, it's all, as with any tech development, you're always limited by kind of your resources. So we're trying to apply for grants and things like that to get this type of thing funded, because it's pretty engineering intensive. And we're trying to work with folks at MIT and industry to kind of get this developed. But I think this is a really, really important thing that we're continuing to work on.
All
Hey,
right.
Dr.
Oh, go ahead.
sorry.
Sorry. No, that's right. You go ahead.
Emani.
Hey, doctor.
Hey guys, how are ya? Hey Nick, hi Steph.
Hey,
Say hi, Paul.
That's Paul. Hey Paul. Looking good, buddy.
How's it going, doctor?
Good, good. Great to see you guys again.
Yeah,
you.
we'll see you in about a month.
Yeah.
I had a quick question about the stem cells. Sorry to bounce back, but the second option, because we were talking. Oh my God.
Oops. Did they drop off?
Yeah, I think so.
Okay. We'll get back to them. We'll get back to Stefanik in a second.
Can I just ask a really quick question about a Fontan versus a bivent? What would you say a not like a bad bivent versus a really good Fontan?
Yeah. So this is a common sort of debate and question that's out there. I would say that it's a little bit early to really tell. We don't have data to really inform that question. If I had to be really honest, I would say that what we would want to do is we would want to take patients who have a certain type of anatomy and compare the outcomes with bivent and Fontan in the long run. In a way, it's a little bit comparing apples to oranges. Let me tell you why. If you do a biventricular repair and you have a good result, you can have a normal circulation and do well. Okay. But there is a proportion. There's a proportion of patients that we're starting to understand better now. There's a proportion of patients who don't do well with the biventricular repair. I think we're understanding it better. I think it's the patients with EFE. I think we're getting a better handle on who those patients are. If you fall into that category, patients who have a not good outcome, then it can be worse than the Fontan. But if we can get better at predicting who those patients are, it's that will help us to really say you're in the category that Fontan may be better than doing a very high risk complex biventricular repair. But I will say that the other reason why it's apples to oranges is because the Fontans do great early after a Fontan. And I think that it's, in the right patient, Fontans can do well. You just have to really keep on top of making sure that, you're watching out for things and just, keeping healthy, staying in exercise programs and really kind of doing things well. And I know a lot of Fontans who are doing great as adults, and I want everybody to be that way as a Fontan. However, we are seeing occasionally Fontans who come back with issues regarding lymphatic problems and other issues that that I have to figure out how to handle. And seeing that has made me really think more about biventricular repairs, especially if I know that the Fontan is going to be a not good Fontan. There are certain risk factors for not a good Fontan. And, you guys may already know this, but, what makes a patient what are risk factors for the Fontan, right? Risk factors for the Fontan, if present, include things like pulmonary vein stenosis, right ventricular dysfunction. You have tricuspid valve disease, tricuspid regurg, heart block or pacemaker. You're on a pacemaker for some reason. You have lung issues, either one of your, you have some lung disease. You have pulmonary artery problems. So if you have any of these risk factors, I'm going to push really hard towards a biventricular repair. If you have no risk factors, I'm still going to push for a biventricular repair, but I'm going to want to make sure that I am convinced that the biventricular repair is going to have a good long-term outcome before I say we should do the biventricular repair. And so in patients who have low or no risk factors, I think that it's worth doing it. And the reason for that is because, if you look at all the data, you look at all the Fontan data, the reality of the matter is that some people are saying that 50% of patients may have some complication that impairs that impairs long-term quality of life. Now, again, it's really hard to make that apples to oranges comparison, because with the bivent, you might be, you're upfronting the risk. You're making that risk upfront. It's around the time of the procedure, and and things like that. So this is the big question, and I've been trying to figure out how to answer this well. I think it is something that's going to require probably, a large multi-center trial. The problem with the large multi-center trial is that a lot of it is technique dependent. Not everybody does bivent. So if you're not comfortable with the bivent and you're forced to do a bivent, you're not going to have a good result. So it doesn't make sense to compare it that way. So, if you think about how the study would have to be done, it would really have to be done comparing our data to other people's data. And then there are other things that come in, because the way we follow patients may be different from the way other people follow patients. And so this is why this is going to be and it's going to take years to know the answer. So it'll be taking a decade or so. So this is why, if I want to give you a scientific answer about is a bivent better than a Fontan based upon data, it's going to be hard to do that. But what I can say clearly is that if there are risk factors for the Fontan, it's an easy decision. If you don't have EFE, it's an easier decision. Yeah. And if you're already a Fontan, now we're starting to take down a lot of Fontans. If you're a Fontan and you're having issues, well, then it's an easy decision to say, okay, now let's try to go back and do something different. So this is kind of how I think about that complex equation, if you will. And, when I'm talking to families, I try to really, focus on that probability for that particular patient and weigh those risks.
Hey, Dr. Emani. Oh.
Sorry.
Hey, this is Courtney Chevet's mom.
Hi.
My question is related to after we do the full conversion, what is the timeline that if for some reason it's not working, that we could still take down the patching and go back to the Fontan? How long do we got?
Right, good question. Yeah, so I think, so generally speaking, if let's say we're talking about doubling the left ventricle now, Okay, now we're talking about double in the left ventricle. We're doing a staging approach towards a biventricular repair. And I know some of you guys on the call are interested in thinking about the double in the left ventricles. So patients with, now we're starting a new program, for double in the left ventricle to do a staged approach towards a biventricular repair. And the question here is, when is the point of no return? And it's really, the real point is after you do the BIV. After you do the BIV, if you have issues, you really probably have around, 6 months to 1 year within which you have to make a determination about whether there are issues. After that point, you sort of lose the opportunity to go back to a Fontan. And so, as we start to do this and as we start to move this program forward, this is another patient population which we're really going to go quite slowly. We're not going to jump to a biventricular repair until we're absolutely happy that we're going to have a high chance of success, because again, we don't want to burn any bridges. The whole point of all of our staged approach, when we talk about staging, whether that be in HLHS, whether that be in unbalanced canals, whether that be for any patient who has a borderline ventricle, idea of staging, the principles are clear, right? First, do no harm. I do not want to eliminate, I still want to stay a Fontan candidate, okay? And I'm gearing my approach towards staying a Fontan candidate until we get to that biventricular repair all along, right? So the first dictum is do no harm, and then the second dictum is really nudge that left ventricle along, or that hypoplastic ventricle along, to nudge the circulation towards the bivent, and see, and the third is to really see what the response is, okay, and really tailor our approach to the response that we see, so that if a child has a ventricle that isn't responding the way we want, don't force it to a BIV. If it is responding the way we want, then that tells us something important. And so this is really kind of the whole, the principle behind the staging approach, if you will.
Dr. Emani, this is Carlene. So I just wanted to jump in. So Tyler is now a Fontan patient. You operated in May. What are the chances now that, sorry, the new baby's here? I was pregnant last time I saw you.
Oh, congrats. Great.
So what are the chances now of a Fontan takedown if his left ventricle starts to grow with him?
Yeah, great question. So let's talk for a second. And pardon me for in the beginning, I was trying to type, with actually correct spelling, but I'm free forming now because I can't talk and type at the same time. So pardon me for any spelling errors or shorthand on my typing here. So let's talk a bit about Fontan takedown. So Fontan, we have taken down several Fontan Fontan circulations, and particularly for patients who have still a small left ventricle. Once you do the Fontan, you really do decompress that left ventricle. So that's one thing that we have to remember. We do decompress the left ventricle, but it's still possible to go back, to go to the BIV. And this may require a staging procedure to kind of get the left ventricle kind of rehabilitated. But one thing that we did before we did Tyler's surgery that we're now doing more of, and that we didn't talk about in the past very much, was this concept of the reverse double switch. And this really kind of came in the last year, and the reverse double switch has really changed the discussion quite a bit for a lot of our families. And for a lot of you on the call that I'm going to be seeing in the near future, you're going to be hearing me talk about this more, because in the past it was either you got to use the left ventricle as a systemic ventricle or it's Fontan. But now with this, what we're realizing, you know, we can actually use the left ventricle as a pulmonary ventricle. So we're in the reverse double switch. What we're doing is we're using the left ventricle as a pulmonary ventricle. And so the blood, the left ventricle is going to be now pumping to the lungs, and the right ventricle is the systemic ventricle. And that means that the right ventricle will be the pumping chamber to the body. And in that setup, we don't need the left ventricle to be, you know, normal size. We don't need it to be totally normal. We can have it pump half as much. So that's kind of a unique situation. It's a more complex surgery, but you know, once we started doing it, what we realized is that you know we can actually do it technically, and you know, now we really only have experience with 6 patients. So again, I'm not ready to like, you know, claim victory on this yet, but in those 6 patients, I've so far, with, you know, 1 year follow-up or whatever it is, we've had, you know, pretty decent success, I would say, you know. So if you've had a Fontan, this is something that we're going to start looking at. We actually are at our most recent meeting, we looked at our Fontan takedowns, and in patients who were doing well and at the time of Fontan takedown, they had good outcomes. The issue is if you wait too late to take the Fontan down. So a couple of patients we had who had Fontan failure, they were pretty sick coming into the Fontan takedown. If you wait too long, then the outcomes aren't as good. So that's when we had some mortality. We had some patients who didn't make it because we waited too long.
And what is that time frame usually?
Time frame.
Or that you're seeing?
It's more a physiologic time frame than an age time frame. It's if you wait until Fontan failure to go too long, that can be a problem to take it down. But generally speaking, if we're going to take down the Fontan, I like to do it before 10 years of age. Although our oldest patient is around 14 years of age.
Hey, Dr. Emani, sorry, my computer had died. But the quick question I was just asking.
I saw the shoot before
Yeah.
you went blank.
I know, I'm sorry. The stem cells, the second one you had explained, not the mesoblast, the other one, was that something you said had to be done during the Norwood if it was to be?
Yeah.
Okay.
So the ELPIS trial, again, the ELPIS trial is the trial where we're using stem cells for the right ventricle. So it's not for the left ventricle; it's for the right ventricle. And we have to take we take the child's stem cells at the first stage. We send it off to Miami to have it kind of grow out. Then we get the stem cells back at the time of the Glenn, and we inject them into the right ventricle at the time of the Glenn.
Got it. Okay.
Can I piggyback off of what he was just talking about for a second?
Sorry.
Just can I go back to what you were talking about with the kind of the Fontan versus the BIV just a few minutes ago?
Yes.
I've had a lot of people ask me kind of what the, like how we decided to go the BIV route versus the Fontan route. So I've had a lot of people say, you know, we have our home team saying that a Fontan is the only route to go, but then they reach out to Boston or to a different facility, CHOP, and they say BIV is possible. And we were in that boat too. Our home team said, we don't think a BIV is safe. Fontan's what needs to be done. And then once we talked with you, you said, no, I think a BIV is actually the way to go with Emmy. So can you talk a little bit about maybe why those stark differences are there? Does it have to do with technological advancements that y'all have that maybe other facilities don't, or just the level of care in the CICU there? Can you just touch on that a little bit?
Great points. Yeah. So I think you're right. I think that there is. I am a little bit disturbed by the what I would call discrepancy in sort of what is considered to be standard of care across the country. and especially in our congenital heart disease patients who have, more complex heart disease. And the trend that I'm seeing is multiple fold. I find that many centers are starting to, shy away from complex repairs, and recommend single ventricle more commonly. And I think the reason for that is because there's a microscope on outcomes for a lot of centers. And as much as we hate to admit it, we're humans, and when you have things like the STS database and other institutions that are that sort of are grading centers, and that is public information, it affects behavior. So I found a lot of my own colleagues will say, you know what, yeah, I might be able to do a complex biventricular repair, but if something happens, it's not good for the patient, for one thing, but more importantly, I don't want to take a risk. Now, the other things that go into it are technical, and the technical considerations are, if you're only doing, a BIV a year or a BIV every couple of months, you're just not going to be technically facile with the techniques, and you're not going to feel comfortable with it. As you can see, we spend a lot of time thinking about this, and so we're developing new techniques, even in-house, to kind of, iterate and make it better. And I think that gives us a certain level of comfort. And a lot of other places, I don't mean to say us only, but places that do it a lot are going to feel much more comfortable with doing it. Now, I do think that there's also a lot that has to do with teams. It includes ICU, it includes imaging. It includes, nursing. All of these aspects go into making a bivent actually work. I can do my part, but if, nursing, doesn't know what to look out for, and we end up with, giving a little bit too much fluid in the first 24 hours, for instance, or something like that, it can really, really change the outcome. So, it really is important that it be a programmatic approach to doing this. So if you're looking at your center, you want to make sure that they do these, even if they're offering a bivent, you want to make sure that they're doing it frequently enough that they're going to have experience with this. And so I think these are some of the things that go into these discrepancies. And the other aspect of it that we just, is obvious from this phone call, and, that many of you have brought up, is education. It takes a while for even me to get information out to my own colleagues at other centers. So a lot of places, it's just that diffusion of knowledge and expertise takes a while to occur in a very dynamically changing field. So this creates another setup for that difference. That's a great question.
Hey, Dr. Emani, this is Courtney again. I know we've had this conversation, but I think there's several heterotaxy families on here. So can you just piggyback that same conversation with the need for taking into consideration of heterotaxy and how they're at even higher risk with the Fontan and things like that?
Yeah,
that
great.
really sold us.
Yeah, so there are specific considerations for patients with heterotaxy. Some of them have to do with the way that the cardiac anatomy is situated, and particularly actually in heterotaxy patients, the conduction system and its location, the valves and how the valves look can be very different. In addition to non-cardiac conditions and issues particularly related to liver, lungs, and kidneys, the immune system, and things of that nature. So I think that heterotaxy, when you're thinking about heterotaxy patients, you really want to be able to take all of these into consideration all at once, because that really is a little different. There are some key differences, particularly in the valves for me, and some of the anatomic considerations when I'm doing a repair. That's made a difference. And this is a situation where actually the conduction mapping has come in huge, because I can, I've gone in at times and been like, oh, okay, I know where the conduction system is going to be in a heterotaxy patient, and it's like completely different, way off. So these are the types of considerations that I look at when I'm, thinking about heterotaxy. The other thing is with the liver. We watch the liver very carefully after a cardiac procedure in a heterotaxy patient, because it can be much more sensitive. And I think that's why the Fontan in a heterotaxy patient can be a little bit more risky than in the non-heterotaxy patient, because that higher pressure in the Fontan may not be as well tolerated in the long run. And so it's another reason why I may tend to push towards a biventricular repair in a heterotaxy patient.
Charlene had a
Emani?
question that was pretty good. The doctors that are doing bivents in other facilities, are they training with you guys first, or they just kind of learn on their own?
Yeah, I mean, some of them will have trained in Boston, but I think many of them will be doing it as a part of their clinical practice. I would say that until now, we've not had a sort of single place to talk about biventricular repair. We've been thinking about having a symposium where we talk about biventricular repairs. As you can imagine, for whatever reason, maybe it's partly our fault, but the whole issue of IV versus Fontan has become almost like a emotional affair. I mean, there are places that are like, totally anti-IV, and they're like, oh, good Fontan is so much better than a bad IV, and they're vehemently opposed to it. It's almost visceral. And then there are those that are like, oh yeah, this is the wave of the future. We've got to embrace this. This is going to help our patients so much, and it's gonna be great. And I feel like that has made it very difficult to have conversations. When I go to meetings, like, just to give you an example, guys, at our AATS meeting, what they asked me to talk about is like, when would I, why I shouldn't be doing a BIV, or when I shouldn't be doing something like that, why I shouldn't be doing a BIV. It's like, it becomes a very touchy subject. But I'm hoping that with time, as we get more experience and more data, that people will become more comfortable with it. And I think part of it has to do with having the right educational platforms, and really having platforms like this where families kind of help stimulate discussions with their home teams. I think that, a lot of you guys, we've had some really good discussions with your home cardiology teams. And I think, that's the way we sort of ultimately do the right thing for the kids.
Yeah, I think one thing that is really important that we learned throughout our journey was the fact that we were never even told from the get-go that there was another option. We were never told that we could reach out to other facilities, because we were kind of funneled into this mindset of the surgeon that was here in town was the best in the world. And while he is an amazingly talented, great surgeon, the facility is not there, and they're not ready for these complex cases. And luckily he did, in so many words, tell us that, and said, I don't think she's a great IV candidate. I would do a Fontan, and I would stage it out in 3 different surgeries. But that was something, actually reaching out to you, Dr. Emani, was something that another mom on a Facebook group that I met recommended. She said, make sure you reach out to Boston, reach out to Dr. Emani, see what their opinion is, and go from there. And I think that is kind of a hard thing that I know I've talked with a lot of families about, is they just feel like they're funneled into their one hospital, and the education just isn't there yet. So hopefully, and I know you touched on that earlier, hopefully that's something that we can make way with in the future, because I know it's really kind of an issue right now.
Just out of curiosity, if I were to ask the group, at what point how do we do that? I mean, is there a point in your journey where it becomes important to have the discussion? Is it better prenatally? Is it better to be done, after kind of the neonatal period? As a parent, when do you feel is the best time to be really introducing a concept that may not be standard?
I would say, I mean, my opinion would be prenatally, but I don't think there's really a right or wrong answer to that.
I agree, prenatally.
Yeah, knowing the option as soon as possible, I mean, just gives you the opportunity to weigh everything as a parent versus, like we found out 2.5 years down the road kind of thing.
Yeah.
I also think once before, you give birth and before you understand everything about it, you're already planted the seed of this idea that there's a little bit of like a world you have to explore rather than give birth and then you're told, here, we do A, we do B, we do C. And that's maybe to have like a bit of a broader idea of how.
Well, this is something that we may want to think about as a, as a group, trying to, think about ways that we can partner with other family organizations to kind of help think about not so much. I'm not saying that BIV is the only way to go. There are a lot of patients who are Fontans who are doing great, and I'm not against Fontan, and don't get me wrong. I mean, what I want families to have access to know what are all the options, whether they are standard of care, whether they are, a little bit out there, and have the ability to ask the questions and really know where everything stands. I'm not going to claim that we know that the BIV is better than the Fontan. We don't have that data yet. But to know that there is another option that has some potential advantages in the right patient, I think that's the key. And how we make those decisions is going to be, again, it's going to come down to the individual patient. It's not like a blanket statement, BIV better than Fontan, Fontan better than BIV, because it's really dependent upon the child.
I definitely think being told all the options early on is better. Like with us, we knew that our daughter had a VSD, but obviously I guess they couldn't tell about the cords when I was pregnant with her. And then she went for her routine, like first postnatal scan, and they found the cords. And she was like 5 weeks old, and I was hit with like in 2 weeks' time she was going to have an operation, and they were going to give her a PA band. Then I got told some really not great things about the Fontans, like some kids don't make it past 4. And I was just sat there with like a tiny little baby. Why am I being told all of this now? Why wasn't I told, like, okay, we think she's got a VSD, but there is a possibility, like in rare cases, this can happen. And, let's educate you a bit on Fontan and give you some helpful, useful information, not just to say, oh, you might have a Fontans and end up needing a heart transplant. That's basically what we were told. And we were like, what? And so then I spent the last 3 years trying to educate myself on what a Fontan is. And so I'm in the UK, and same, only found out about you from a group on Facebook. And if I'd never joined that group, I would never have known.
Yeah.
So yeah, there definitely needs a bit more education, I think, for the families.
For sure.
What would you suggest for us as families that would be able to facilitate more medical advancements in general, like fundraising or just bringing awareness to not only for you guys, but other facilities? Like, what can we do to make this better? This conundrum that we're in where they're just so scared, but what can we do, knowing what we know from what we've learned with our kids, that we can get other facilities more open to it, and also, what I mean.
Well, I have to say that I am duly impressed with all of you for staying engaged at a very high level. You have a lot to think about with your own, children, your own family, your own lives, to then dedicate time, to helping others, and that is like huge inspiration to me. I think that you know, there are probably ways to do this, and I think it really it would probably engage, you know, involve, you know, kind of organizations. You've sort of had some experience with the New England region. Maybe you can share a little bit about what you've done, but I think, you know, having publicly visible, accessible, you know, place to go is kind of where we start. And then from our standpoint, being able to then, you know, provide information at various levels, whether it be symposia for physicians that want to learn more about it, whether it be kind of actually technical stuff and learning how we can fund research at various institutions that are onto something that can help, you know, kids with congenital heart disease. I think there are a number of ways of doing this. It's you know, it takes really a lot of brainstorming and some organizational effort. But several of you on the call have done this in the past as well, and I would welcome a way of bringing all of them, you know, all of the minds together.
What do you have any specific organizations that you like? Because I know there's a pretty, for lack of a better way of saying, a contentious relationship with the American Heart Association and CHD world. That's the nicest way I could say it. What do you think would be the one that would work best for what we would need?
It's a good question. I don't know. I agree with you. I think one thing about the American Heart Association, I was initially really hoping that they would, you know, they have a pediatric arm, but I think they're just inundated with the adult side of things, and it becomes really hard to get, you know, things moving. But I know that a lot of you guys have you know, developed local organizations, and you know, I don't know, Anne Marie, do you want to talk a little bit about what you've done?
Sure. So I run the New England, It's My Heart New England. So we're a support group for families all across New England, and we partner with the Children's Heart Foundation, the Adult Congenital Heart Association, and the Mended Little Hearts chapters in the area to do like a education conference every 18 months. So just as we were talking, I was thinking maybe we could help sponsor like a bivent symposium or something like that to get the education out there with those same groups of people. Because Jill, to your point, I think the Children's Heart Foundation is a nice way to start, and Melissa is a fan of Dr. Emani, so it will be easy to get her on board. So, and there's a new Conquering CHD of Massachusetts chapter that just started this past fall, so I can also get them on board.
I really appreciate, you know, having a concerted effort and everybody putting in their, you know, their time and effort to try to really, you know, bring awareness up, and again, I want to make sure that we do it in a way that is, you know, reflects what we're thinking about. We just want to you know, present that this is not definite. This is not the cure all be all. I'm not trying to claim that, you know, we have all the answers yet, but to be just very transparent about what is possible, but what is changing very quickly. And when you have something that's changing very quickly, you know, you're automatically working on information that's 5 years old. And how do we make info be more real time? And that's something that even we at Boston Children's are starting to do more of. We're working on databases to kind of keep track. So if you ask me today, how many biventricular repairs have you done? I can pull up, I can just click on a button and say, okay, it's 350 biventricular repairs. And then I can answer a question. So when I'm talking to a family, I'm not giving them information that was my last publication, which could be, you know, could have been a year or two ago. So I think that there's a lot that we are working on, and these are the types of things that will help inform both parents and caregivers across the world.
I just want to add one thing, if that's okay. The facilities, you were saying that the hospitals obviously have their own motivations for how they make decisions. Don't you think so much of this problem of not getting parents all the information they could have just has to do with the hospitals wanting to keep the patients, you know, in their system because that's better for the hospital, not that the God forbid would say that the person informing the parents are bad or have bad intentions, but it seems to be the way it all works out is that, you know, if you're with our hospital, we'll try to keep you here so that we can, you know, do our thing. But what's going to motivate them to refer them to a different hospital like Boston? And I say that with being very grateful that when I was pregnant, I was with NYU in New York and they sent me to Boston. A doctor had the attitude of, there's new things, you know, coming up, and in Boston they're doing it, and I'm going to send you there to get, you know, get on board with that. But that was, I was lucky to have a doctor who was open like that and who said, you know, here's where they can help you. It didn't, and then where we are now, they have the attitude of a more closed attitude to that kind of thing. So I see it as just within hospitals and within amongst themselves. Not parents can help change that, but I think something.
I think that's certainly one. The other issue is now it's becoming increasingly obvious that insurance companies and payers are driving a lot of care decisions, and that's a trend that we're seeing more of. That is, families that want to come to us are getting pushback from you know their insurers, and that's like the worst thing to have to go through all this. And we put a lot of emotional energy into sort of saying, okay, we're going to do this, and then all of a sudden it's somebody else who's dictating what can happen or not. So I think that there are a lot of things that we as a community need to emphasize, because it's not like traditional care like in adult world where if you have a hernia, it gets fixed this way and it's the same way everywhere. It's just our care is not the same, and that's something that we're having to deal with.
Dr. Emani, this is Bernie Heine, Eliana's dad. Just, I know that there's a lot that probably goes into actually publishing a study under scientific terms. The problem with some of the studies that we've seen, though, is just it takes so long to actually get the data that by the time the study is actually published, that's 5 to 10 years old.
Right.
And that's probably also impacts like whether or not you're getting FDA funds or grants or whatever it might be to do that. But is there not any other way to publish data that's more real time, albeit with the appropriate caveats that maybe not enough has been concluded on? Because I think some of it with some, maybe not at Lori in Chicago where we're at, but some of these heart centers probably just don't even know themselves what all is out there because, they're limited by what data they have available to see. And if there's not studies or some sort of data on it, like they probably don't even know that a lot of places don't know that you're doing BIVs on DILF patients, for example.
Yeah.
So I don't know how you balance that, but how do you get the data out there quicker, I guess?
Yeah, I think that's really important. I think it has to do, there's always this balance between how quickly you get the data out and how robust the data is. And that's the balance that we're constantly trying to strike. With many of you, I have no problem saying I've done 2 patients with this, 3 patients with this. I can't go to a conference and convince a cardiologist or a surgeon to do something based upon numbers of patients that are less than 30 or 40, because that's what they consider to be the right power to actually detect any statistical issues. So this is why the publication, this is the limitation of the publication route. And I think we need to have both pathways available to allow us to keep track and like I said, in a very dynamically changing environment, and where we're developing new things on a yearly basis. Great. Any other questions? I think I'd love to be able to do this kind of, we can do this on a regular basis, if it would be helpful. And, I think many of you are doing this, amongst yourselves, and from time to time, we can either do it as a free form like this, or we can talk about a specific topic. I thank you for sort of staying engaged and keeping me in the loop, and just let me know how I can help.
Oh, we'd love to do this again. Just I'll email. We can talk about how often you would like to do it or how often you can. One quick question before you go is heart failure and transplant. Do you find that bivents, when they do fail and need a transplant, are they sort of in a better position because they don't have liver and lung issues versus a Fontan who would need a transplant?
So we looked at that in the past, and what we found is that Fontan patients who undergo a transplant, as long as you do the transplant before they've developed other end organ injury with liver or kidney failure, that the transplant can do well. It's interestingly, the transplant had the most sort of issues, if you will, in Fontan patients who had preserved ventricular function. So if their heart function was good, but they had other reasons for Fontan not doing well, those are the patients who really struggled after a transplant. And that's probably because they have some degree of liver or kidney disease or lymphatic disease that persists even after the transplant. So in a way, you don't want to transplant too willy-nilly and too quickly, but on the other hand, you don't want to wait until a Fontan patient develops end organ injury before going to some sort of durable support.
Hey, Dr. Emani, I got one question for you.
Sure.
Great. My name is, so my son, Jay, had a biventricular repair done in Boston almost 3 years ago by Dr. Del Nido. And his next step is he has a conduit from the RV to PA. And so I just want to get an idea from you, kind of like what typical time frame is as far as, changing out of the conduit. I know it really depends on the child with size and the blood flow and all that. But is there like a typical time frame that you guys look at to see like when is the best time to do that?
I would say that once we start to see that the gradients are increasing across the outflow tract, beyond 50, that's when we tend to say we should start thinking about changing the conduit. But in some patients, it may be sooner, because if there are other issues such as right ventricular dysfunction, or if there's right ventricular enlargement, those might be situations in which we may want to do the conduit sooner. So it does depend a little bit upon how the conduit is interacting with the heart and the lung circulation.
Got it. Awesome. Thank you.
Thanks.
And I just had one really quick question. Sorry.
Sure.
I kind of remember you saying before that a tricuspid valve, I think, wasn't so needed in a Fontan's. And so if you were in a situation where the cords were straddling, in your opinion, would you attempt to move it if the end result was the valve you couldn't use because you don't really need it in the Fontan anyway? Or is that additional surgery a bit unnecessary, then going into a Fontan, would that make the candidate worse for the Fontan?
Right. So if you think that you're going to go to a Fontan, I would not move the papillary muscle or do anything with the chordal attachments. If you knew that you're definitely going to the Fontan, generally I wouldn't mess with it unless there's leakage or something else that needs to be addressed. But it also means that you might be, if you have two good size inlets, you have a good mitral valve and you have a big VSD, it may not be, as a part of the staging procedure, it may not be horrible to take that papillary off and move it and try to get to a BIV and then say that the tricuspid valve doesn't work. That's okay. You have a mitral valve and you don't need the tricuspid valve, so you can overstow the tricuspid valve to use the mitral for the Fontan. So as it doesn't, in other words, working on the tricuspid valve, if you have a good mitral valve, would not impair the ability to go to a Fontan ultimately.
Right, okay, and you'd only do that if you were doing a staged bivent, not
Exactly.
Okay, and would you open, if you knew you were going to do a Fontan, would you still open the heart up to have a look, just to like double check there was nothing you could do, or you just trust the imaging you had?
There's some situations in which looking inside makes a big difference.
Yeah.
Okay. The imaging doesn't always give you everything you need, so it's there are some nuances to the intraoperative decision making.
Okay, great, thank you.
Great.
Another question about valves. Do you find the patients who have mitral valve or really any valve issues are faring worse when you have to replace them? Do you feel that they would be better if they had bad valves and they went to a Fontan versus bad valves and tried a bivent?
Okay, so a very different situation if we're talking about a Fontan versus a bivent. If you have a biventricular circulation, I worry less about replacing valves. I think they tend to do reasonably well as long as you come back to replace the valve before you start to develop problems. On the other hand, if you have a Fontan, I think having a valve replacement it can be a major risk factor, and I worry about that. So if I have a patient that has a very difficult valve, that would push me towards trying to go to a biventricular repair if possible.
Melody valves, how you doing with that in bivents?
Yeah, Melody valves are working. They work well for the younger patients who have a really, really tiny, really tiny valve. And I find that they're probably about a 4 to 5 year valve option. So in the smallest children, that works well. But then after that, generally, you can dilate, get them bigger, but then they ultimately need to come back for a valve replacement around 5 years. At that time, we're able to put in an adult size valve. So it works well for the right patient population. We're now working on developing a valve ourselves, an expandable valve for kids that we're hoping can provide more options and more durable options.
If you
Dr. Emani.
Replacement route, how many replacements do you see people have in their lifetime, or would you expect them to have?
It gets more spaced out the bigger the valve gets. So early on, it may be it might be necessary every 5 years or so. But then after that once you get beyond the first decade of life, it becomes more spaced out. So a valve replacement could go 10, 15 years, or if you have a mechanical valve, can go 20 to 30 years.
Okay, and that's always open heart surgery, or sometimes?
If you have a bioprosthetic valve, maybe you could get a valve-in-valve replacement, but otherwise for the mechanical, clearly it is open.
Okay.
Dr. Emani, one more valve question, but for pulmonary valve atresia, what have you done for pulmonary valves during bivents historically, if there isn't a valve there or the valve can't be repaired?
Yeah, so there's pretty decent experience with using different types of valves. And it includes the homographs, it includes femoral venous valves, it includes porcine or bovine valves and homographs. So there are a whole host of options that we can use. And that has actually, that works pretty well. Again, when do we have to come back to change those? It depends a little bit upon what size the valve is when it goes in. Many of those can be amenable to transcatheter valve and valve replacement. So that's kind of a nice thing about the pulmonary position. That's pretty well established. But some of those conduits can go for a long time without needing to be replaced.
And I know you had mentioned in Cannon's case, you may leave it a valveless conduit to start with, but is it typically, do you typically open the pulmonary valve in a stage 1, or do you leave that for stage 2?
In some situations, we may open it in the stage 1 as well. Yeah.
Okay, thank you.
Yeah. Great. Thanks, guys. Well, I really appreciate all the comments, and I look forward to our next meeting then. And in the meantime, if you have any questions, feel free to email me, and we'll talk again soon.
Thank you so much. I appreciate it.
Okay.
Thank you.